Hello. My thanks to Professor Mary Dixon-Woods and the Healthcare Improvement Studies Institute and everyone listening today. I'm going to talk about improving the evidence for improving cross-sectoral working. I'm Professor Niro Siriwardena, Professor of Primary and Pre-Hospital Healthcare at the University of Lincoln, and I lead the Community Health Research Unit. I like this quote from Helen Keller. And in my opinion, quality improvement is as much about connecting people, cooperation and collaboration as it is about processes and measurement. Just by way of definition, cross-sector collaboration is when two or more organizations work together across sectors, industry, non-profit and government to achieve mutually beneficial outcomes. I'm going to talk a little bit about why cross-sector collaboration is so important, and then give you some examples from the pre-hospital sector where I'm working of how we've done this and what effects it's had. So firstly, a few thoughts about why cross-sector working is important. It's important to understand quality in terms of the triad of effectiveness, safety, experience. And quality improvement for me is about troubleshooting, the act of analysing and solving problems and improving processes. Complexity is important. We need to appreciate the complexity of health systems, multiple moving, interacting structures, such as in the case of ambulances, people and processes. Fragmentation of services is a huge barrier to quality improvement. Connectedness is about the relationship between individuals and organizations, between staff groups and with patients, within internal organizational boundaries and across sectors. It's important for dealing with complexity and fragmentation, and this is particularly so in the pre-hospital setting, where contact with services is always part of a pathway of care with internal and external boundaries. Internally, for example, with Emergency Operations Centre, where calls are received and dispatched, and then frontline responders, including community first responders and ambulance staff, are sent to address a problem and help a patient. Relevance is also important. It's about relevance to the problem, the improvement we're trying to achieve and the context in which we're trying to achieve it, but also taking heed of the needs and views of different stakeholders, trying to increase ownership of the problem and its solutions, and to improve the credibility of an improvement effort and its outcomes. I think cross-sector collaboration is important in defining problems and solutions. And I'm going to give some examples here. In the Pre-Hospital Outcomes for Evidence-Based Evaluation Programme, we worked with patient groups, ambulance services and clinicians, ED clinicians and primary care, together with commissioners to develop patient-centred outcome measures for ambulance services. Through around 30 interviews of patients and relatives who had been seen by the ambulance service, we found out what was important to patients: getting help in a timely way, continuity across the care pathway, but also, importantly, good communication, explaining what the problem was, what needed to be done, taking account of patients' needs, doing that with professionalism, and attending to the ethical aspects of care, so creating autonomy where possible, and instilling confidence to make people feel reassured, even when they were at their sickest. In another study looking at pain in the pre-hospital environment, we interviewed patients, relatives, ambulance and emergency department staff to understand what was needed and how care could be improved. We had looked previously at pain management and found that only 2/5 of patients with chest pain or fracture were given analgesics. Patients valued explanation of the condition and reassurance that treating pain wouldn't affect care down the line in ED. They wanted information about treatment options available and being taken seriously. Pain needed to be assessed better, understanding that some conditions led to severe pain only on movement. Non-drug treatments such as explanation, splinting, or distraction for children needed to be used and optimized, while increasing safe drug options. And good communication and coordination along the care pathway were essential. As an example, pain scoring at the time that we did this study was done differently in the ambulance and in the hospital. So in the ambulance, patients were asked, what's your pain? How bad is your pain from 0 to 10? And they were able to answer that. And then when they arrived in A&E, they were asked, how bad is your pain from 0 to 3? That was incredibly confusing for patients. In a study we're doing currently around emergency care for care home residents, we know that medical emergencies in care homes are costly and common and often result in calls to emergency medical services, resulting in hospital transfer costs and hospitalization. And previous research has focused on rates and reasons to transfer to hospital and the decision to transfer to ED. But less is known about care home residents and their relatives' perspectives of medical emergencies, how quality of emergency care can be improved from their points of view. And so in the REACH study, researching emergency ambulances in care homes, we're working with East Midlands Ambulance Service, care homes through the East Midlands Network for research in care homes and REACH, together with commissioners and primary care to understand emergencies in care homes, how they are managed and how this might be improved. And in a recently published systematic review, we found that patients and relatives felt that resources and capacity were important for ensuring that processes were in place for high quality care, but that good communication and trusting relationships between staff and patients and between organisations was vital for emergency care, including providing ethical care at the end of life. Another area that we've worked in across sectors is in developing quality measures. Coming back again to the Phoebe programme, we held a multi-stakeholder consensus event towards the end of this programme to prioritise potential measures for measuring ambulance service quality and performance. 42 participants took part and discussed and voted on 52 different measures or principles. It was a one-day event involving ambulance service staff, patients, public, the commissioners, policymakers, academics, and researchers. And there were roundtable small group discussions and live voting. At each small group, we discussed outcomes from one of three categories: clinical management, operational, or patient-based measures. And after each session, we used software for participants to vote on whether they thought each potential measure was essential, desirable, or irrelevant. And this electric voting meant that participants across sectors were able to get instant results of how they voted and how everybody together voted on each measure. And this was the result in terms of prioritization. The patient outcomes that were thought most important were pain management and symptom relief and patient experience, as well as things like return of spontaneous circulation after cardiac arrest. Service operational measures included things like completeness and accuracy of patient records, over and under triage rates, proportions of calls treated by the most appropriate service, and patient management measures included things like accuracy of dispatch decisions, call taker identification of condition, and compliance with end-of-life care plans. I think the importance of this is that working across sectors, we got a very different prioritization of what was important compared to if we'd just looked at one sector. Going into more detail on pain measures, again, looking from a patient perspective, what patients wanted, and we gave options around proportion of patients who reported pain or were given analgesia, proportion where an ambulance crew had a pain assessment recorded, proportion of patients who had a reduction in pain score, and proportion of patients reporting more than one pain score recorded. You can see that what was important for patients and the public were the proportion of patients who had a reduction in pain score after analgesic treatment. My final example is around developing, implementing, and evaluating interventions. And I'm going to tell you about a study that we published recently called the Ambulance HS2 study. When people think about HS2, they think about railways, but we think about ambulances and hypo strike twice. And in this study, what we were trying to do was to prevent repeat episodes of hypoglycemia. Around 1 in 10 to 20 people with diabetes who have a low blood sugar will call an ambulance again within 2 weeks of an initial call. And as a result of this, a booklet or leaflet with information about hypos and how to prevent them was developed through discussion with patients, diabetes specialist nurses, physicians, GPs, together with ambulance services. And it included advice on hypoglycemia and advice to seek further help from the GP or community diabetes nurse specialist to improve control of the diabetes to prevent a further episode of hypoglycemia. And this is important because we know hypoglycemia can be very disabling, can lead to death even in rare circumstances, but we also know that recurrent hypoglycemia is associated with increased cardiovascular morbidity and mortality. The booklet also had information for ambulance staff to complete when they arrived on scene, including physiological measurements and advice given to patients, and the instruction to go and see their GP or community diabetes nurse. Well, what did we find? We were interested in the effect of the intervention, more precisely if a second call occurred after receiving the leaflet. And we labelled outcomes as successful if there wasn't a further call, or unsuccessful if the call was followed by another call for a hypoglycemic episode. And we looked at almost 5,000 patients over a period of a year when this intervention was delivered across East Midlands. And this gives you an idea of how common repeat calls were across that period of time. So you can see that within a couple of weeks, it's around 5% repeat calls within 3 months, over 10% within 9 months, almost 20%. And we used a non-randomized stepped wedge design where the intervention was rolled out across the East Midlands, across the different counties of the East Midlands in steps at 3-month intervals. And so with this design, you can see that each cluster contributed to observations under both control and intervention observation periods. And this enabled us to account for underlying differences between the clusters in terms of patient demographics. Outcomes were measured at individual level, and this overcame logistical problems problems of implementation, but also ethical difficulties of randomization, for example. So we didn't have problems of randomization in this particular implementation and evaluation. We used two methods of analysis. The first was a generalized linear mixed model analysis, where we looked at clusters. We looked at the level of treatment and at the level of time at which the intervention was implemented. And the results of the generalized linear mixed model were that at time 3, so T1, T2, T3, during the third period, there was a significant reduction across the different clusters for repeat hypoglycemicals, and that took into account things like deprivation, seasonality, so month of year, age of patient, and gender. The other method of analysis we used was an interrupted time series, where we coded calls as a success or unsuccessful, collapses as an average per week, and aligned the clusters based on the time elapsed before and after the intervention, so that everything was aligned to this time naught, where the intervention was implemented across each cluster. And taking into account deprivation, age, gender, and seasonality as covariates, we saw a shift when the intervention was introduced. So there was a small shift, and this was followed by a gradual decline in the number of repeat hypoglycemic episodes over the period of the intervention. So that showed that the intervention worked. In addition, there was an improved care bundle delivery. So the bundle was glucose measurement pre-treatment, whether drug or treatment was administered for hypoglycemia, and measurement of glucose after treatment. And we found in the no intervention, in the observation period, that the care bundle was achieved in 63%, whereas in the intervention period, it was achieved 71% of the time. And we think that was because of the prompt in the booklet to record pre and post-treatment glucose and the treatment, as well as the other physiological variables. So this evaluation showed that cross-sectoral collaboration led to development of a patient booklet-based intervention for repeat ambulance attendances for hypoglycemia. And by working together, it led to successful use of the information booklets by ambulance clinicians to prevent future attendances for recurrent hypoglycemia at very low cost, and increased completion of the care bundle. In conclusion, my conclusion is that cross-sectoral working is essential. It's essential for all improvement because of the need to involve patient and service user contributors and experts, really at every stage of the improvement activity, from start to finish, from design, implementation to dissemination. And it's particularly important in the pre-hospital environment, where improvement efforts cross or might affect intra or inter-organizational boundaries, processes, or outcomes, as shown in the examples that I've given. I think it's really important for accounting for complexity and to address fragmentation. And it helps to ensure connectedness and relevance, so ownership, credibility of the problem and its solutions. I'd like to acknowledge and thank all of the people who've worked with us over the past 20 years on various projects. And thank you very much indeed for listening.
Thank you very much. I'm Claire Goodman and delighted to be presenting today. When you get invited to do one of these presentations, it's an opportunity to look back as well as what we currently know. And I looked at Jan Reid, who in 1998, a pioneer researcher in care homes, likened them to being islands of the old. She drew on the work of Susan Sontag, who'd said that being ill is being in a different place. And once you've made that journey, it's difficult to get back. And she comments that being old seems in many ways similar. We have an island for older people, and we like them to go there and stay there. And in many respects, when thinking about how the NHS works with care homes, there is an element of this othering that we have had to negotiate and bridge and change. So just a little bit of information about who is in a care home. And this paper is very useful because it's looking at projected need for long-term care for people with dementia. And about 70% of the care home population are living with dementia. And as you can see, numbers 251,000 2015 projected to rise to 667,000. And the authors do put in a bit of a caveat on this projection, recognizing that public expectations and policies are rapidly changing. Plus, we have an unknown supply both of unpaid and paid care going forwards. But nevertheless, I think the take-home message is that we are probably going to need some significant increase in capacity for long-term care as our population ages. So what can we say about the care home sector? Well, when thinking about how the NHS works with them, almost half of newly admitted residents actually come from hospitals now. So that means a significant proportion are arriving following critical ill health. Outside of research work, remarkably little is known about the population as the pandemic exposed. And the average care home bed size is, if without nursing, 28, with nursing 30, although that's a huge variation around that mean. And new build are increasingly now 60 to 70 beds. But when you're thinking about cross-sector working, what you really need to understand is that this isn't the NHS, however much we try and create parallel ways of working. So the self-funders account for 45% of people in care homes, with 12% paying top-ups. So only about a third are wholly funded by the state, and that affects how well we understand them and who collects the information. The NHS pays for 8% wholly for their care, recognising that they have the equivalent healthcare needs, but are in a long-term care setting. But crucially, a third of our care home capacity for older people is in businesses of 1 to 2 care homes. So if you're trying to think of how do you work with this sector, it's not as if there is one organisation or even one representative group who can speak on their behalf. But when I'm thinking about care homes, I reference Alison Mills' comment about the NHS and their relationship with care homes, that it's both a solution and a problem. A solution because they provide all our long-term care for older people and actually have almost 3 times as many beds as hospital beds in this country. So they're a solution, but they're also perceived as a problem if they are seen as placing inappropriate demand on our primary and acute care services. And there is a long history of the NHS discovering care home residents and going in to help support, train or educate, and I use this parachute image to capture that. So that could be end-of-life care initiatives, tissue viability, and more recently a recognition that residents now are entering with their own teeth and need oral health and dental support, which previously has not been the case. And in a series of studies that we have done over the years and repeated, there is a consistent picture of ad hoc and inequitable NHS provision to these residents, even though they are completely eligible to full access to NHS services. So I'm now going to sort of have a little reflection of when we think about cross-sector working, whose evidence are we going to look at? And going to the toilet is clearly not a health problem or issue. And many people in care homes, they receive help to go to the toilet. So it's help with their personal care. But it does become a health issue if you develop infection, if you develop incontinence. And I just want to look at some evidence as an illustration of how it all depends how you define the problem. If you define it as a health or social or personal care issue, about how you work together. So this was some work where we looked at fecal incontinence in care homes, and it was commissioned because a series of Cochrane reviews of trials, of which there are many, had very equivocal results, not achieving improved outcomes for people with incontinence, even though there was a reasonable evidence base of what should be effective. So our review looked to develop a theory of what was likely to work in what situation. And what we found was, when we looked at the evidence, that actually it was how you understood the health problem for a care home. So it required those doing interventions that were known to be effective for continence care in ways that a care home could relate to and their staff could implement. So we found it was really unhelpful to create this distinction between continence care and continence problems and personal or intimate care, which is very often the reason why care home residents need to be in a care home. They need help with their activities of daily living, washing, etc. And whilst we knew from the healthcare evidence and research that prompted toileting could be really helpful for some residents, just reminding them regularly to go to the toilet to achieve continence, that only really worked when the people leading the innovation were actively valuing the work of the unqualified and junior staff to whom it fell to actually give the personal care and help with washing and so on, and that they needed to be affirmed as making a crucial and valued contribution to the person's continence and well-being. And then, as I mentioned earlier, 70% of this population are living with dementia. And most of the interventions we looked at just did not consider how dementia affected a person's ability to engage with an intervention to improve continence outcomes. So that really had to be brought into the conversations, and how things like prompted voiding could actually be incorporated into the daily work routines of the care home. So I've talked about that sort of on an individual level of care, but what do we learn about what improves and helps cross-sectoral working at the system level, and whose innovation do we look at? And I have to stress that over the decades, it's not as if the NHS has ignored care homes, quite the opposite. There have been repeated innovations and repeated different ways of working. And the optimal study started by asking all these different people who work in and with care homes, well, what do you need to be effective when you're working across health and social care? And these were the kind of accounts that people said, well, you need to invest, you need to give people the time to actually get to know each other, to provide continuity, and to have opportunities for shared learning. Others stressed the fact that you need age-appropriate clinical services. This is a population where the average age is 85 plus. They have 3 to 4 long-term conditions that they live with, an average of 9 medications, and in the last year or years of life. So this actually gives layers of complexity that would suggest you need geriatrician and gerontological expertise involved. Others stressed governance arrangements, that you needed to actually specify what a good quality minimum service should look like that they should receive from care homes. You'll remember I said it has been a very ad hoc process. And all of these ideas came from people from different disciplines. So we took that learning forward and tested it in 3 sites, all of whom were working in different ways with their care homes. They either had specialist team, were funding GPs extra time, or had individual practitioners visiting the care homes as their role. And here I'm going to talk about the example of finance and incentives. And what we found in the optimal study was that when you invest, when you have the incentives, they can be the context, but not the mechanism for improvement if they're used to create the time to build these relational co-design approaches to work. All of our study sites were using extra incentives and investment, but they were doing it with different points of a resident's arrival in a care home and with different groups of practitioners. So I'm just going to share with you the principles we brought out from that. So what we found was investing in healthcare professional input into care homes was a really important context when that role service person was part of a network of other services wrapped around the care home. So it wasn't all reliant on a single service or a single person. The complexity of the population made that very difficult. So actually, they just needed to be part of a system that they could then cross-refer with as well as take the lead. That these had to be patterns of working that had been negotiated over time. The parachute way of working just wasn't helpful. So in the systems where we saw it working well, people had actually learned how to use the time to everybody's best advantage. And also that it was protected work, that the commissioning group, the employer, valued care home work and protected it, and that it was therefore endorsed as something that was valuable to the system and the organization. And when that was the context, that triggered proactive care from the visiting clinicians. It meant that the work was valued and the care home staff felt respected, and it created common ground. It wasn't just focused on single resident visits. Now, you put the same amount of money in, and it's not a sufficient context. And we actually did show similar amounts of money if the reason for putting the money in was a hostile care agenda. And I'm borrowing from Ken Rockwood here, of where he talks about hostile care, where you invest to stop people using your services. So if the reason was we're having too many admissions from care homes to hospitals or too many demands on our primary care services, that was a very negative reason to invest, and it was not helpful. Where there was no previous history of working, where really these had been set up to sort something out, and also where it was added into the role. So that would be, for example, a GP having to go into care homes as an extra part of their work that would have been shoehorned in without protecting that time, or where there was a reliance on a single practitioner to sort out or work with care homes. When that was the context in how the incentives and finance was used, that triggered deep frustration and a blame culture, an incredibly narrow focus on things like resource demand and not a discussion of what's working well. And when it was single practitioners, staff turnover, that people had nobody to work with and there was no career development in that role. Well, that completed in around about 2017, and we now have the Enhanced Healthcare and Care Homes Framework. And I'm glad to say that a lot of those findings did feed into some of the thinking. And so I would suggest we possibly do now have an infrastructure that could support effective cross-sectoral working. But of course, it will all depend on what the purpose of that sectoral working, cross-sectoral working is seen. And I hope I've illustrated that actually creating common ground like a weekly home round and assessments, if it's done to promote relational working, if it's done to promote a shared decision-making approach, then I think they can be very effective. And that takes us into the other primary care network recommendation, that there should be information sharing and shared care records, which brings me to whose data. So the pandemic absolutely exposed that care homes were hiding in plain sight. It was nothing short of shocking what was not known about care home residents. And it brought to the surface the need for linked routine health and social care data. It brought to the surface the need for access to data, and that was the difference between a good response and a high infection rate and excess mortality. Now, the pandemic hit at the beginning of 2020. We started the DACHA study just before then, and we were looking at exactly these kind of issues, but expecting to have to battle with people to persuade them of the value. Now that isn't the case. And what we are working to develop is a minimum data set as a resource for health and social care, and not just regulation or cost containment, which is often used in other countries, and making care home residents part of a data system a policy priority. Well, those were our aims. It actually now is a policy priority. And so we are in a situation of where we have to make sure that we are not duplicating work that is already being led from DHSC and NHSX, and we are talking to them a lot. So this is what we're doing. And this slide, really, all you really need to know is see it's a 4-year study, and we have completed a series of reviews looking at how you work and what supports implementation practice in care homes. We have looked at the indicators that are used in existing minimum data sets in other countries, and you'll be unsurprised to hear that they are dominated by healthcare indicators and not indicators that reflect quality of life. And we have also been looking, just completed, Barbara Hanratty, a national survey of care home information that is already collected by care homes. And it's worth noting that care homes collect a vast amount of data. It's just that at the moment it is siloed. So we're now working with the Health Foundation, with 2 integrated care systems and possibly a third, to actually identify care home residents in routine data sets so that we can begin to create resident data sets from data from hospitals, from primary care, and from urgent and emergency services, and also from local authorities, so that actually that will reduce the data capture burden on care homes. We will be able to take out that kind of resource use information that currently is constantly being requested from them from routine data sets. And then we will pilot with 40 care homes an electronic prototype to collect the care home components. And there, the whole emphasis is on making sure that actually the data reflects the priorities and interests of the care homes in ways that can ensure the data is useful for care as well as those external to the care home. So to summarize, I've taken you through a quick overview of how the NHS is working with care homes. And I hope the take-home messages are there's phenomenal heterogeneity in this sector, and that directly affects engagement in the past and now. That the evidence to date has been dominated by healthcare questions, and that needs to be balanced. I would argue we have got core principles of how to achieve good, effective cross-sector working, and that the enhanced healthcare and care homes framework, working with primary care networks, has huge potential to roll that out. We are seeing increasingly in our research a massive shift to working with care home staff to reflect interventions that are sustainable and meaningful. And we have a post-pandemic opportunity with threats to create a data-informed narrative that can reflect both the interests of the NHS and social care to address the health and quality of life of residents. Thank you. And I'd just like to acknowledge the funding from the NIHR, that these are my views, and the huge DACHA team that is working together to achieve what we hope will be an integrated data system. Thank you.
Thank you so much, Claire Goodman there and Niro Siriwardena, with a compelling accounts of both the value of cross-sectoral working, but also the challenges. I'm sure there's many of you have got questions, do send them in, but I just wanted to ask you both, is this the difficulties of working across sector? Is it about the barriers between the sectors, or is it actually about a culture question, that there are different cultures which are not understood by the various parties? Niro?
Yes, I think that's a great question. Sadly, I think there are barriers, cultural barriers between organisations, and cultural barriers still between professional groups. And I think those must develop very early. I think it's very important to develop a professional identity, isn't it? As you know, I trained as a doctor, and that was really very, very important. But actually, when you're in the real world of health and social care, those barriers need to be broken down very quickly to be able to function effectively. And I don't think in every place, and it was great to hear the examples of work that Claire's doing, but I don't think there's a system for enabling interaction between different organizational groups and between different professional groups to the extent that we need it for quality improvement and cross-sectoral working.
Claire, what are your thoughts on that? And it's interesting, isn't it? Because there are clearly different priorities for each of those sectors. I mean, you know these walls that get built, don't come into my sector, keep them in your sector. That's going on a lot.
I think the barriers are what I alluded to, was that these are multiple small businesses, and we tend to think of, when I'm speaking specifically about care homes, we tend to think of them as one thing, and there's such a huge internal variation, and they don't necessarily communicate with each other. So there are 7 representative organisations for the care home sector, and I think some of them have done really well and come to the fore in articulating issues because of the pandemic. So I think that's a sort of structural issue that we can't change, but we need to recognise. I think I don't think anybody here is looking forward to going to a care home themselves. So that's a social dread that is a barrier before you even start talking about how health and particularly the care home sector work together. So those kind of things sit there. And then I think Niro is really right about about how do we get people to work together, because it's only when you spend time with each other you discover that actually the stereotypes, that sometimes they apply but not always. And I think there's been some really nice quality improvement work done, Adam Gordon in Nottingham, where that's featured heavily on developing quality improvement collaboratives, which is echoing, I think, some of the principles that you heard today around building trust, building relationships, and also finding out why certain professional groups find it incredibly difficult to engage. So, for example, why is it that even though GPs hold all the responsibility for care homes and access to medical care, even though they are interested, that they still struggle to take a big role in that? And I think that is something about how you negotiate the role, but also how you allocate resources to give people the time to talk to each other. It just doesn't happen spontaneously, unfortunately.
There's a good question from the audience for you, Claire. Are the studies for housebound residents, they seem to be missing out on similar priorities that care home residents receive?
Oh gosh, that's so yes, it's the answer to that. Yes, so the issue, and I mean, and we're still only looking at it only beginning to look at it from the perspective of domiciliary care. So even the people who are relying on unpaid sources of support are not known and not particularly well understood. And one of the things that we've been challenged on the DATCHA study is, why aren't you doing extending the minimum data set to people who receive domiciliary care, because they're probably on a journey that might, hopefully not. Most people do not go to a care home, and I think we've taken that on board and are exploring if we can do that more. But I just think the studies on people alone at home or with very little support are very few and far between, and that reflects the fact that they fall under the social care umbrella, so therefore don't get the access to health resource as much. Would be my hunch, but yeah, I would encourage anybody, this is absolutely desperately needed to be done as further research.
So very much a lost population, and perhaps
I think so.
Yeah,
I mean, I can't talk with any authority apart from say we only find the people who the services know about. So it's you're sort of in a double bind there.
I often think actually we don't think about the carers in those situations, because they're often people who would willingly contribute data because they they, you know, they're responsible for the care, they're very invested in it, and they want to be part of the system but feel themselves excluded. Now, another question, which actually comes from Mary Dixon Woods. So we've got.
Well, I'll pay extra attention to this.
Yes, we're saluting. Can you expand on the concept of hostile care? Mary suggests the idea of hostile design may have some similarities. Niro, do you want to take that first? Is there a kind of a hostile care concept going on in some of the sectors that you look at?
Yes, I honestly hadn't heard of this concept before, expressed in that way, but was certainly aware of it in the way that we design projects. So I think I really liked your example, Claire, of, you know, not focusing on negative things, but all of our projects and programs focus on trying to improve experience rather than you know, focusing on, although I talked about troubleshooting, it was more in the sense of improving experience and providing good care, because I think the last thing that, for example, medics want to hear is we want to do something to reduce costs, or you know, but if you talk about improving care and improving quality of care, they're much more likely to be engaged with that, whether it's, you know, nurses, GPs, ambulance clinicians. So that's always been our focus, but I hadn't come across this idea, but I think it's a really good concept.
Well, the concept, I did name check Ken Rockwood, who many people will know as the sort of led a lot of on frailty work. And he used this phrase in response to a question at a Cambridge plenary when somebody said, you've been in Nova Dalhousie for a long time. How has your research influenced how your hospital engages with people who are frail or assessed as frail? And he said, I have seen 7 changes of management in my hospital, and all of them are only interested in it for its ability to provide hostile care, i.e. stop people going into intensive care if the frailty score suggests that they're not going to benefit, which is completely the opposite of what the purpose of his research has been. And I've actually had a backwards and forwards correspondence with him, and just that we've talked about doing an editorial on it, because it's an easy outcome, isn't it? Did not go to hospital, did not cost more, and therefore it's a shorthand, but if it dominates, then it creates a narrative of despair, I would suggest. Hostile design, I know very little about that, but I feel I should go away and look that up.
Another question I wanted to ask you both was whether there were sectors that are not thought about much in this field. So obviously, you know, you're thinking about ambulances and care homes, but other sectors, for instance, like the arts, you know, having heard about the, you know, the engagement through arts that this institute does, are there other sectors that we aren't including that really we should be including?
Yeah, I think the answer must be yes. And the nice thing about working at a university is we interact with people that I wouldn't interact with normally. So, for example, archaeologists and people working on heritage sites. And we've just recently completed some work looking at well-being of volunteers working on heritage sites. And then there are all of these, if you, for want of a better description, social prescribing type interventions or activities where actually the ideas around improvement and quality, you know, could be applied and thought about. But Claire, I'd be interested to hear your thoughts on that.
Well, I think the pandemic is, when you're trying to do research and you can't actually get into care homes, has triggered a whole load of different ways of working. And one of the things that we've done on DACTUA is that we're working with the National Association of Activity Providers, and so they provide, as it suggests, you know, interest and art and poetry and dance and so on. That's their every care home has somebody who's responsible to enrich life, and we've been working with them to make talking about preferences and priorities to feed into our research as an activity. So, you know, today you can do bingo, you can do poetry appreciation, or you can talk about how you think your data should be used and what information. And they've been talking with us. Well, you know, to be able to do that, we need to do visual resources. We need, you know, and so we're tapping into their expertise to help enable us to think about, because it's been quite revealing how residents feel about their information being shared, as you might imagine, and their voice is very difficult to access, and usually we rely on family carers or staff to talk on their behalf. So yeah, absolutely, I think these are again, it's what necessity pushes you to my shame. I should probably have thought of it before that.
I feel a whole new seam of research about to be uncovered. Thank you both so much. Really terrific presentations from both of you, and we're really grateful for your contributions. Thank you so much. So now we've got another of those fabulous featured fellows. This time it's Ruth Baxter. She's the Health Foundation Improvement Science PhD alum.